Hello everyone. Welcome back. Let's continue from where we stopped in the previous session. Before that, let's quickly recall what we learned in the last video. In the last video, we described normal age-related structural and physiological changes in the kidneys, explained reduced renal reserve and its impact on fluid and electrolyte regulation, and we recognized unusual presentations of renal dysfunction in older adults. By the end of this session, the learner will be able to 1. Identify dehydration and common electrolyte disturbances in geriatric patients. 2. Integrate medication risk, functional change, and renal trends to anticipate and prevent renal deterioration. Let's continue with seeing how dehydration and electrolyte issues present in geriatrics. Dehydration in older adults is common, often subtle, and can be easily missed. The common contributors include reduced thirst sensation, limited access to fluids, fear of incontinence, cognitive impairment, and diuretic use. It may still be present even when blood pressure appears normal, urine output continues, laboratory changes are mild or subtle. This is why dehydration in geriatrics should be suspected early and assessed proactively, rather than waiting for obvious signs. Let's look at the electrolyte disturbances. These can also present with early, non-specific symptoms, yet cause serious harm. Common patterns include from hyponatremia to confusion, falls, and seizures, from hypernatremia to lethargy and weakness, from potassium imbalance to arrhythmias and weakness, because older adults have reduced physiological reserve. Even small electrolyte shifts can lead to major clinical effects and rapid deterioration. Finally, we will see how to prevent renal deterioration in older adults. Preventing renal deterioration in older adults depends on early risk recognition, careful medication review, and acting on trends and subtle change rather than waiting for obvious renal failure. Medication-related injury is a major and preventable cause of renal decline in geriatrics. Older adults are especially vulnerable to NSAID-related renal injury, diuretic-related electrolyte imbalance, ACE inhibitor-related renal decline, drug accumulation, and toxicity. Because renal clearance declines with age, polypharmacy significantly increases risk, especially when dehydration, infection, or reduced intake is present. Do you know that early renal warning signs are often subtle and trend-based? These signs include rising creatinine trends, even if still within normal range, reduced urine output trends, electrolyte fluctuations, cognitive or functional decline. Advanced practitioners need to know that functional decline often appears before clear laboratory abnormalities, so changes in mobility, energy, alertness, or oral intake should trigger renal assessment. In order to prevent avoidable harm, advanced practitioners should routinely ask, has intake changed? Such as the fluids, appetite, or oral intake. Is renal reserve limited? Meaning higher vulnerability to small insults. Could medications be contributing? Like new drugs, dose changes, or high-risk medications? What is the risk if this worsens overnight? You need to anticipate and act early. This approach supports early intervention before renal deterioration becomes irreversible. In conclusion, early recognition, careful medication review, and attention to subtle changes and trends are essential to prevent rapid renal deterioration and avoid irreversible harm. We've come to the end of this session. Thanks for watching. See you soon.